Hello, everyone. Thanks for joining this webinar sponsored by Fenton Health, where I'm going to be talking about radiation-induced skin reactions and early signs of damage in different skin tones. Thanks very much for this opportunity. Make sure you stick around to the end and pop your questions, thoughts into the chat, and I'll make sure I answer them at the end for you.
My name's Naman. I am an advanced practice therapeutic radiographer, currently working in research at the Institute of Cancer Research and the Royal Marsden in Sutton. I also work as the National Clinical Advisor for Allied Health Professionals for Macmillan Cancer Support 2 days a week. And I also do a oncology podcast called Rad Chat. Try not to talk about it too much today, but it's a good podcast if you want to have a listen. We've done over 200 episodes, and there's a few charities on the bottom that I do kind of work with and things like that. And it all kind of ties into what I'm doing today from a radiotherapy perspective. To make of interest. So I'm going to go into a bit of a buzz term, I guess, still, equality, diversity and inclusion, and why it builds into this sort of work, especially when looking at equity, which I'll come towards the end, go into a bit about radiography, history, skin, and then specifically around radiation-induced skin reactions. Just as a kind of disclaimer, I suppose, I've got some images of skin reactions that are of sensitive areas, and they are quite they can come across a bit disgusting or a bit juicy to people. So if you're eating or drinking anything, I'd probably say when it comes toward the end of the presentation, when I talk about them and go through them, maybe stop in case you get a bit wheezy. Otherwise, there's a few bits and pieces that I'm going to talk about that might be a bit triggering for people or a bit too direct. I am quite blunt, but I think this topic needs a bit of bluntness and directness around it because there's lots of things that we aren't doing right still. So hopefully I get that across. So when we think about equality, this is what equality is. So the EDI aspect, if you look at the four people on the screen, so obviously different types of people, different characteristics that they have. This is what equality means. So in healthcare, so in the NHS, we're offering everyone equal access to what they want by giving them all the same type of bike, regardless of what their protected characteristic is. Somebody in a wheelchair, somebody who's really tall, a child, we're still giving them the same thing regardless of what they need. So this is what equality sort of stands for and means. If you look at it a different way, is this kind of tree. It's an infographic that I really like, but it's that the tree is the system, so healthcare, whatever it is still leaning towards one side, but we've given both these people the same sort of way to access the apples. So obviously the person on the right-hand side has the same side ladder, but the system is leaning towards one person and they're able to get everything that they need. So yeah, just another way of looking at what equality is, and hopefully I'll come across as to why I'm trying to give a different view of it. When we look at radiography, so obviously I work in therapeutic radiography, and there's also the diagnostic side, so there's two different types of radiographers. But in the history, so this was, I think, in the 1960s, when people went for a chest x-ray in America. So I think in 1968, the perception was that people with brown or black skin or someone with a higher BMI, so body habitus, were harder to penetrate. So harder to penetrate meaning like there is the myth that black people have thicker skin. They were given a higher dose of radiation. So people, so if you look on the left-hand side, sorry, so people with black skin, they were given an increased exposure of 40 to 60% more radiation compared to white people, and people with higher BMI, so someone as said extremely obese, they were sometimes given between 5 to 15 times more exposure. This is again where that equality side has started, that while people wanted to offer the same sort of treatment for everyone, it was slightly different based on different myths. There was no research into this. So yeah, it might have been quite difficult to report if you were having any experiences of side effects because of this to your skin. So radiation-induced skin reactions isn't necessarily always to do with radiotherapy. It has also been to do with the diagnostic side like this, where we were giving a lot more dose to someone like me, so a person of colour. You'd be happy to know we don't do this anymore, as far as I know, anywhere in the world, but it's just to showcase where historically this has all sort of started. When we look at skin, so obviously we're talking about skin specifically, this is a cruder version of what's called the Fitzpatrick scale. So the Fitzpatrick scale, hopefully you know, was a observation-based self-reported tool that was designed, I think, again in the 1960s and 70s, which was originally designed for people with white skin. So number 1, 2, 3, and 4 is what was used for classifying white skin. And then eventually they added on number 5 and 6 with people of color. There wasn't any evidence as to how they went about this, but adding the number 5 and 6 on. So actually lots of studies, probably within 5 or 10 years after this was first produced, highlighted that for people of color, people from ethnic and diverse backgrounds, that it isn't fit for purpose. It doesn't really work. But actually, again, from dermatology and then eventually into radiotherapy, this is another kind of those racialized myths or problems that have kind of presented and have led to where we are now, where things aren't necessarily always equitable for all types of different people. And actually, even with this, there's lots of misconceptions. So if you look at the literature around the Fitzpatrick scale, apart from the colors and how the skin looks, going from 1 most likely to burn in the sun up to 4, 5, and 6 least likely to burn in the sun. That's what has been written, and also why people of color like me, growing up in India, were always taught to believe that we're invincible in the sun and don't need to wear sun cream. But I'm a number 4 and I do burn if I don't put sun cream on. And actually the rates of skin cancer have been increasing in people of color because we've always just been thinking that we are immune, or that our skin is slightly thicker, so we have better protection against the sun, which isn't true because all of our skin is the same. The case study that I use often, and I absolutely loved this head and neck cancer patient who we treated where I worked before. So their skin was very pigmented. I don't like the Fitzpatrick scale, but it'd be towards the end of the Fitzpatrick scale. They had head and neck cancer as we treat their left tonsil, and towards the end of their treatment, they were starting to show that they were struggling with their skin in the head and neck region, so mainly in the neck. But it was very sore. It was feeling warmer to them, and actually, quite often when I saw their skin or saw them in the corridor, they would say that their skin felt like it was on fire, that it was really painful, really hot, itchy, and sore. But on the surface, it didn't look like this infographic on the right-hand side. So this is an infographic which kind of 2 things merged together. So the effects of radiotherapy on skin cells underneath, so how deep it goes for the radiation-induced skin reaction, and on the left-hand side, it shows the assessment or observation, which is based on the Radiation Therapy Oncology Group scoring system, so RTOG, which goes from 0 to 4. And as you can see, it's based on white skin, and it uses the term erythema, which doesn't necessarily work for all types of people of color. So yes, erythema underneath the surface of the skin is about an increase in blood flow, etc., but on the surface looks very different. This actual printout, I was trained on this little tool. I was given this printout laminated very nicely and used it to assess people's skin when they had a skin reaction, but actually it doesn't work for all different types of skin tone. So this patient was assessed originally by me in the corridor, just as though I could tell that their skin reaction was getting really bad and needed to intervene. My nursing colleagues at the time, two of them, they both saw it as well and said, no, looks fine, send the patient home, even though you could tell the patient was in a lot of pain. Just clearly were confused as to why they were being sent home, and no interventions whatsoever. But yeah, they came out the next day, the skin was all broken down, was really, really sore. It started to bleed in certain areas where the patient would be really uncomfortable overnight. And then actually the patient had to be admitted for sepsis, or suspected sepsis at that point, because of how bad the reaction had got. And I challenged my colleagues, which was quite scary. Didn't really go down very well, their answer was that quote on the bottom, just saying that textbooks only show white skin. So we sent the person home because they were looking for redness. And redness was never going to work in this person with pigmented skin tone. I'm sure if you're listening to this, you may have come across different patients like this or heard stories like this. It's still happening. I think it's just something I really wanted to point out because the patient was obviously very upset, in a lot of pain, did not trust us after that. I was very, I don't know, just really struggled with the trauma of it. And I think we already put our patients through so much through chemo radiation. To then have this happen to them, and then they were really struggling post-treatment. So the psychological impact of it was very high. And actually, this little tool, I've seen some of my students have still been using this sort of way to assess different skin tones. When you look at Google, it doesn't really help the situation. So I just typed in skin reaction to see what would come up. So obviously all of these people are showing white skin. So it's not showing a variety of skin reactions across different skin tones, how they might look. And obviously here you can see clearly that redness, like the tool before, is what you would see on someone with white skin, or even children, that shows on the top one there. I think it's just really interesting that, yeah, obviously Google is one of the most trusted search engines, is where most of our patients will go to find out what's going on. As much as we hate Dr. Google, it is what people would do. And even if I have a problem, I'll still go to Google first, or that's how I'll find something. If we delve in a bit deeper afterwards into erythema, same thing, still showing white skin, different types of reactions, whether it's a dermatological skin condition or it's a burn or something like that, it's still showing erythema as on white skin, showing the redness and things like that. So if patients were to use that tool, so the RTOG tool that I mentioned earlier, it's actually supposed to also be able to be used by patients, and sometimes for self-reporting aspects of it, which is used in clinical trials. The term erythema is what will come up. So if I'm a person of color, or my patient is black or brown, and they type in erythema, this is what they'll first see. So maybe, again, they won't be able to find necessarily what they need to. You look at radiation-induced skin reactions, very similar again. I think on the bottom left, maybe there's one person with sort of brownish skin tone that is showing, but primarily, as you can see, more the scientific ways of it. And actually, I've just realized in this screenshot that my face is on the bottom one, and I didn't see that before. So it's another good video to talk about skin reactions, but mainly shows white skin tones. Really important that actually, again, if patients even just look at on Google with radiation-induced skin reaction, which isn't necessarily accessible for everyone, it will still firstly show white skin. There was a study by Lester et al. In 2020. So this is a screenshot from their paper. But what they did is, during the COVID-19 pandemic, where patients or people all across the world were experiencing different skin reactions after having an infection of COVID or something like that, they went into the New England Journal of Medicine database to see if there were any images of people of color. Because again, people need representation. If they want to look at a skin reaction on their skin tone, they need to see it for what it needs to be. So they went through data from just before the pandemic, so 1992 to 2017, and they found that only 22%, which I think is around 5,600-ish was the number of images, were of people of color. So you can see on the left-hand side the different screenshots, and on the right is the correlation of the most brown versions of what was found. They're still not really showing any black skin tones. So again, even during the pandemic and other things, but actually if you look at the historical data, that's a long time period, so 1992 to 2017, showcasing that people of color haven't even been included in images there. So again, we're still showcasing that equality side, that we're trying to offer people the same type of treatment, but it's not really equitable for everyone. So let's just talk about skin really briefly. Again, couldn't find an image of a skin diagram of a person of color, but this is one that I've used before, and I know I'm allowed to reuse it because of the licensing laws, which I've been told to be careful of. We should hopefully know about skin. It's one of the basic things that we go through, in healthcare degrees or courses or whatever, but it's a fundamental organ. It's the biggest one in the body. I think it makes up around 15% of our body weight. There are lots of different important things like thermoregulation. It's also a protection barrier to stop things that we don't want in our skin getting in. It's three main layers. You've got the epidermis at the top, which is a few millimeters. This has what's called the keratinocytes in them, which also has stem cells, which help with healing and kind of the reaction to inflammation. Further down is the dermis, which has all the lovely different structures that are made of protein. So you've got collagen and all the other structural elements. So when patients have a skin reaction, this area will also be damaged. And then further down is where the lipocytes are, the hypodermis layer, which we don't really need to worry about too much for this talk. Looking on the right-hand side is what happens when, so radiation, so my lovely animations at the top, either sun or radiation from radiotherapy hits the surface of the skin. So as I said, the epidermis has that layer of keratinocytes, and obviously lower down is where the melanin production begins. There's two different types of melanin. I'm sure a few different colleagues, we all got different levels of melanin all throughout the year. It will change every single day depending on how much sun there is. The two different types are the brown, black eumelanin, which is more abundant in people of brown or black skin, someone like me. So it gives me my dark hair, dark eyes, dark skin features. And then the other type of melanin is called pheomelanin, and that it colors pinkish parts, so lips, nipples, stuff like that. So people of color were more likely to have that, more in abundance of brown, black eumelanin. And actually, if you start to think of that ultraviolet radiation, so with the animations at the top, as soon as it hits the surface of the skin, more melanin is produced, whether that is in whatever different process it is. The process is called melanogenesis. Don't want to bore you too much with it, but that hand kind of structure that shows on the right, melanin is produced and it's pushed up into the keratinocytes up there to help protect the green circular thing, which is the nucleus. So as more melanin is produced as a result of that superficial light hitting the surface, what that's doing is it's these little blobs is protecting the nucleus from any kind of damage. So obviously, the less protection there is, the higher the chance of skin damage and then potentially skin cancer as well. But this is what will continue to happen all the time. So every time we go outside, and even if it's cloudy and there's a tiny bit of sun, our body will produce a bit more melanin to protect our skin that is being exposed to sun. Or if you go on a plane, for example, I haven't always done it, but sometimes if it's a day flight, I might wear sun cream on my face because actually you're closer than the rays coming through. That's how you get more of a radiation dose. But this sort of process is similar to what will happen when people have radiotherapy. And that's all it really is producing more melanin as a result to the radiation that's hitting the top layer of the skin and that's penetrating in. So this is an example of obviously radiation hitting. So the red kind of lightning bolts at the top is the radiotherapy, for example. And what will happen is as the radiation penetrates through, because we're trying to reach that target underneath the skin surface, even if it's on the skin surface, you'll still get some of this penetrating deeper. But let's say, for example, we're treating a breast cancer deeper down, the epidermis, as it says, will be damaged, but also the basement layer, which is quite important because that helps with kind of where the stem cells are. So if the stem cell numbers decrease, that inflammation will increase within the first 24 hours of a dose. And you get free radicals, reactive oxygen, stuff like that in the basement membrane, and then it causes more damage. This is why for radiotherapy, we have dose and fractionations. We only give a certain amount every day, usually 5 days a week, knowing that we can allow the cells in the area enough time to heal. And I point to the two areas in the dermis, the hair follicles and the sweat glands. So you'll notice in an area that sometimes people's hair will fall out in that area. They'll have decreased sweating. That's because of this damage that we're causing through radiotherapy to the area. But also, the melanocytes will produce more melanin. As you can see, the brown blobs moving to the top. And obviously, this will present differently. So this process underneath is erythema, but on the surface, erythema presents a bit differently, or pigmentation, if you want to call it that, on the surface. But actually, there's also, I should point out, there's evidence that this sort of process can happen within a few hours after as little as 2 gray of a dose. So historically, when I was taught to tell patients that their skin reaction might occur toward the end of the first week or the second week of treatment, it's not entirely true. There's evidence from 2016 and even before that radiation from radiotherapy can start to cause this process within a few hours of that first dose. So even though we might not be able to see the changes in the skin on the top, underneath the skin, this process is obviously happening all the time. As soon as the radiotherapy reaction occurs. Just going with the skin side of things. So when we think of equality, as I said, hopefully trying to get across that black and brown skin isn't thicker than white skin. But the equality side of things is anyone who goes for radiotherapy will have been consented, hopefully in the UK, on these what they're called now, Royal College of Radiologists, RCR consent forms. They produced these a couple of years ago to help standardize the process for clinicians all across the UK and for patients. They're really good. They give you the expected and common side effects of the percentage, so what to expect, tiredness, skin changes, etc. However, just to point out, so that head and neck patient who I use as a case study, they were consented on the head and neck versions of these, but as you can see, I've put in red, all of the forms say redness. Redness does not work for brown and black skin, same as it didn't for my patient before, and exactly why they were dismissed by my colleagues. They were looking for redness. So one of the first things that patient did afterwards was go through their consent form to see why they hadn't figured out or why they hadn't been picked up or caught with this reaction was because it's her redness. So the informed consent side of things is something for you to consider, that actually maybe look at the consent forms as well. If they say redness, and a person of colour has been consented on it, it's not correct for what they should be getting. Since this, it took about 18 months or so, but I have been able to change these for the RCR. So now any patient going for radiotherapy in the UK will be consented for a skin reaction on any type of treatment with the correct terminology for their skin tone, whether they're white, brown or black. A little win, quite proud of it, but just something to get across that if you do need to look at your own consent forms for whatever aspect of work like care you work in, go on the RCR website and any of the consent forms, so like breast or head and neck, for example, the terminology, just copy it if you want to. It will help to distinguish a reaction on people of colour. Something else, I mentioned the RTOG already. So erythema, so that's the Radiation Therapy Oncology group. So assessment tools, we love an assessment tool because it helps make our lives easier. The other one that's quite well known as well is the common terminology criteria for adverse events, CTCAE. So these are originally designed for clinical trials, and then we use them now because they work. But they also say erythema. So technically speaking, yes, that's correct. As I showed you with the process of melanogenesis underneath the skin, that's what happens with erythema. On the surface, though, that doesn't necessarily mean that you get redness. And I'll come on to erythema in a little bit. But I just wanted to build a picture that equality-wise, we're not necessarily being equal. We're giving everyone the same thing, yes, but people of colour aren't necessarily getting what they need to. And that's because erythema, so the British Association of Dermatology, you might have already seen this before, 2021, they came out with a statement saying erythema comes from the Greek word erythos, which we know, which means red. It's an increase of blood flow, like I explained. I think common misconception. So for someone like me, South Asian background, I shouldn't be able to burn, but I do. But the more important thing, as I've been trying to lead up to, is that redness itself is misleading. It's not inclusive of all skin tones. So even for white skin, you might see pink or purple changes. But the main thing for people of colour, so brown or black skin, which I've got some images obviously later to showcase, is that subtle kind of darkening. So where the treatment area itself becomes subtly darker than the surrounding area. That's what's really you need to look out for, but also the different pigment changes. So it might be purple changes, sometimes yellow kind of changes as well in the area on black skin. So for my skin, it might go maroon and then be darker than the surrounding. But also for other skin conditions, so outside of radiotherapy, there is kind of grey changes. So I had a friend who has black skin and has always struggled to get a diagnosis for eczema because the area that she's had eczema in has been grey. But now, because of all of this work that's finally come out and showcased her skin, she has now got a diagnosis of eczema. The GP didn't believe it was a problem, but now knows that it's not just red that happened. Hopefully we can start to move away from the one-size-fits-all model, because this is what we should be doing. So where equality clearly isn't working, which I've kind of hopefully shown you, this is what equity is. This is what we want. So all these 4 people want to ride a bike, but depending on their different characteristics, we offer them the bike that works for them. That's how it should be. And that's the same for skin reactions or whatever it is. Looking at it a different way. So obviously equity is better than equality. However, while the person on the right has got a taller ladder, there's only 2 apples for them to go for, because the system is still working harder towards one direction. So is the other person on the other side. But we still need to fix the system, and that's kind of where hopefully we can start going towards. So I talked about the Fitzpatrick scale, a better version, which I've used, and very proud to have worked with Flam Health for a little tool that they've developed and have put out. Make sure you get in touch with the Flam Health rep at the email I said to get these sent out to you. But this is a tool, 2015, Ho and Robinson. It's still based on the Fitzpatrick scale. However, what they did was measure the different levels of melanin within the 6 scales that I showed you earlier. So actually, and I've put the little bits in red on the left to give you a bit more context, but so for white skin, actually, number 1 would be it, whereas before it was number 1 to 4 on the Fitzpatrick scale. Brown is the bigger element, because there's a lot of differences within that, so 2 till 5. And whereas on the other one, it was number 5. And then black skin here is still one of them towards the end, but you can see the differences in pigment changes, just a better way than the Fitzpatrick scale. And actually something around terminology here, the reason why I put it as white, brown, black is there are lots of different terms for describing skin, and darker skin is something that's been used often, and that's what I've always described my skin as. But a international consensus in 2023, which went through with people of lived experience, but also different clinicians from different backgrounds, highlighted that actually saying that I have darker skin, what is it darker from? It's still saying darker from white skin, so still highlighting that white skin is the norm. They're trying to say, hopefully what I tried to say earlier, is that the skin is darker than the surrounding. Yes, it's more words, but it's more inclusive of people, and it's trying to highlight that everyone has a different skin tone, and actually my skin going darker in the area that is being treated or has like skin damage or whatever, that's what we should be saying rather than just saying someone has darker skin. And terminology really matters. I think later on I've got a little infographic to help highlight that as well. I know feet are a bit disgusting in growth, and luckily in radiotherapy we don't have to work with them as much, but just a good image from Wounds International, that actually knowing what the norm for your patient is really important. So like I mentioned about my friend who has eczema, their skin goes grey and the eczema lesions on their pigmented skin. Also, sometimes patients might have different skin conditions within the radiation field, and we will make that a lot worse from the radiotherapy treatment. It's really important to get a good baseline. In the dermatology side, medical photography is used really well. We don't use it as well in radiotherapy, if we can even find a camera in the department. But it's really important to know what the baseline is. Do they have damage in the area already? What is their skin tone like? Because again, someone whose skin or aspects of their body that is in the sunlight a bit more will probably be a different shade to what is maybe covered by the skin. So maybe someone who's having their breast treated, for example. It's really important to know that if patients have had sun damage recently and they're about to start radiotherapy, it's going to get significantly worse very quickly. If you work in radiotherapy or you know or come across patients in it, in the summer periods or when the sun's out a bit more in the UK, we really try and highlight that patients need to cover up, because if they get skin damage, even a tiny bit in the radiation field, it's likely to get even worse when they start having radiotherapy. Skin bleaching is something that I have come across a few times in different communities where they want to not be as pigmented, not look as black or brown. So they might have bleached some aspects of their skin. Again, this will be a lot worse, or it'll get a lot worse due to radiation treatments. It's just something to be careful of. Just cultures want to be a bit fairer. Coming from India, this is something that I've definitely come across and been told that because I am a bit fairer than most Indian, I'll get married off a bit quicker. But I've married a white English lady, so I think my grandma was very pleased anyway, regardless of that. So it's just something to consider. Something else with the African skin, there is evidence that research has been done that they do have more oil glands, and that the glands or the hair follicles sometimes tend to be a bit larger, which ultimately, because the skin's a bit oily, is just something to consider when offering products or baseline and things like that. Actually, some of the benefits of having oilier skin is that they don't age as much as people with less oily skin. But this is also where the myth of black doesn't crack comes from. So just something to be careful of when it comes to highlighting differences in skin tones. So that's hopefully getting across that we really need to get a good baseline of knowing what their skincare regime is. In radiotherapy, the Society of Radiographers came out with some guidance in 2020, which highlight that we shouldn't be recommending any specific products because there isn't enough evidence to suggest one's better than the other. But ask your patients what their norm is. They should be using a very generic basic moisturizer for the area prior to treatment, so pre-habbing, so getting their skin ready for treatment, and post-treatment, probably forever. Some departments, obviously we'll talk about the Planning Health webinar, that, the Flamigel RT is a norm for higher risk patients in some departments, and it's something that I'd advocate for because I've seen that it does really work. So I've not just been paid to say it, I have seen it in real life. And actually that patient, their case study, having put Flamigel on their skin healed a lot quicker than we probably would have done if we hadn't intervened afterwards. So just something to consider, find out what your department does. And especially, moving on to this bit, is that we shouldn't be looking for redness. So as I pointed out, so look at your standard operating procedures, work instructions, whatever they're called, consent forms, if you have local ones for different things, shouldn't be looking for redness. The terminology needs to change. Try and get a good baseline, because that is equity, that is finding out what is good for that person. When it comes to people of color, when the visual cues aren't necessarily going to give you everything, touch is really good if you can, and see patients will know if their skin is a bit warmer to touch or not, but you might see that it gets a bit harder in the area, it gets a bit warmer just because of the damage that we're causing from radiation. If you have access to an infrared thermometer, this will help to getting, again, a baseline, knowing what it is, and then post-radiation, post-radiotherapy, knowing what the differences are afterwards. But also listen to your patient. Lots of times we don't even ask the patient how their skin's feeling, but that's quite a good place to start. And then, as I said, using that photography to monitor it. Just an example. So not necessarily a radiotherapy skin reaction, obviously, but on the left you've got acne, on the right you've got psoriasis. So you can see the differences in how erythema versus pigmentation, how it looks. So you can see on the white skin, the redness is quite clear, whereas on the black skin, the acne or the psoriasis, you don't really see redness. On the acne, not at all. On the right-hand side, I would argue that even the tiniest little bits of red that you see is because of the imaging that's been done, the quality of the light. You're actually just seeing the capillaries underneath the skin. It's just something hopefully gets across the differences. This is equity. This is knowing the difference in your patient in front of you. Hopefully this will help you examine your patients a bit better. I think the next few images that are coming up are a bit more in your face if you want. So if you're eating or drinking, just a little warning. This is again trying to show the difference between how erythema presents on the surface. So on the right-hand side, you can clearly see the defined edges of radiotherapy that we've treated and the redness within it. This is about someone who's finished treatment already and it's post-treatment. But that's how erythema presents on the surface. So it looks red on the left-hand side. I mean, you can challenge me if you want, but the only bit of redness I see is the wound, which is underneath, which is normal. But the rest of the skin is, as I said earlier, like darker than the surrounding. And you can see the contrast in the treatment. So the right breast, that we treated, the contralateral breast or the abdomen of the patient is a very different skin tone. But that's how the erythema presents on the surface. And it's just something to really highlight that you're not looking for redness all the time. It could be, I mean, that's not exactly subtly darker than the surrounding, but that would have gradually got to that point and you will be able to see the differences. And this is where knowing your patient is really important. The next image is definitely more graphic. But just while this is someone with white skin, it's just an example of how different, more sensitive areas need a good examination as well. So obviously this is someone that's having lower GI treatment, but you can kind of see the edges have also got a bit brown. I know it's not a brown skin patient, but the only image that I really had to show how it could start to go a bit brown or a bit more maroon for different skin tones as well before looking like it goes darker than the surrounding. But again, it's just important to make sure you check out the areas, have a look. Obviously this has been very, very sore for the patient. Hopefully this is what we can try and work towards. So justice, fixing the system. I know it's propped up by wood and being held by like rope and stuff, but it's better than what it is now. So both these people are able to access the healthcare system, whatever you want to really call it as, so they're apples with the same tools, but get what they both need at the same time. That's kind of what we want to be working towards. As I mentioned earlier with the Royal College of Radiologists consent forms, I've just screenshotted at the top the differences that are written for white skin, brown or black skin. So working with the RCR to make sure that all the consent forms have this kind of consistent terminology for how skin reactions look. And then bottoms, working with Flan Health, very proud to have done it. So they've produced this amazing skin assessment tool for wounds. So it gives you the different types of terminology to use for skin reactions. And obviously just get in touch with them. They'll send you as many as you need over, but it's just a good way to look at it. This tool is obviously based on the Hogan Robinson, that infographic I showed earlier. But what you do is measure the inner side of the arm, if it's possible, with these skin tones to find what it should look like. The reason it's the inner side of the arm is because as we walk and we go normally, it's the least likely to kind of be in the sunlight. It's a good representation of what the true skin tone is. So obviously as soon as it's a tiny bit sunny, more melanin is produced, so that I showed earlier. Just something else to maybe use as a reference if you want to, just a QR code for a paper that I published October, so quite recent. obviously it's quite in your face saying structural racism, because technically speaking, for me, that's what this is. Skin tone hasn't been considered as consent forms. Assessment tools are only based on white skin. This is the problem. It's been quite scary to call it out as it is, but that's what it is. If you need a reference for how skin reactions look on different skin tones, hopefully this can be something that you could use, or just lift the terminology from within it to help with your tools and stuff like that. If I can challenge things like this by myself, I think anyone else can. It's really important that we start to provide equity and then a bit more justice for our patients going through treatment. Hopefully I've got that across today. So yeah, thank you very much for listening. My contact details if you want to get in touch. And cheeky plug again for the podcast with the QR code on the right hand side. But as I said, any questions, either contact me directly or go through Flan Health at info@flanhealth.com. And if you want to get that skin tool, make sure you email them. They can send you some across through their local reps. Yeah, thanks all for listening.
So we've had a couple so far in the Q&A. So Rachel, you asked about assuming similar issues with those on chemotherapy. So probably the skin reaction kind of changes. So yes, exactly like how you might see palmar-plantar syndrome, so hands and feet, things like that, where you wouldn't necessarily always see redness on someone with brown or black skin. You might see that subtle kind of pigment changes, things like that. I've actually worked with the amazing UConn's team to update the terminology on their national triage tool. So for UConn's helplines, things like that, anyone working in acute oncology. So I'm not sure if they're live yet, but they should be soon. So that has all the correct terminology, and we've gone through the whole document as well. So if there's any other conditions or like rashes, for example, it doesn't just say look for redness anymore. Because obviously if you're doing a telephone assessment as well, you're not necessarily going to be able to see the reaction. So you are triaging through the phone. It's the same for radiotherapy if you've ever had to triage through the phone. So I'm hoping that will help as well with that moving forward. Thanks, Astrid, for a nice message in the Q&A. And they've got another message saying, another question saying, seeing that there are the white skin and the black skin, do we give the same care? I think when it comes to radiotherapy, we are evidence-based, so all of our patients will get the same care, treatment-wise. When it comes to assessing a skin reaction, I think that's what I was trying to focus on, is that we probably aren't offering the same care to everyone. I would argue, and I have done throughout the presentation, and for the past couple of years, that a lot of our tools, medical education, is based on white skin, so we're probably not providing the best or the top level care for people of brown skin like me or black people as well. And that's been something that's been going on to the 1990s. So the RTOG and CTCAE tools were developed in the 1990s. They haven't changed their terminology for skin reactions since then. Actually, there's another tool which is kind of patient-led as well, called RISR. That's in New Zealand and Australia. That also just talks about redness, but that's also patient-led in some aspects of the tool. So again, all the main validated tools for the world have been designed and based for white skin. So I don't think from an assessment level we do offer that, whether that's chemotherapy, radiotherapy, immunotherapy. One of the papers that I referenced about the terminology, so the international census, 2023 it came out. If you look in it, it identifies problems with assessing people with diabetic foot ulcers and things like that. And that's one of the issues as well, that actually, since we've started to talk about these, how differences on black skin, we're not supposed to look for erythema, you should be feeling for heat. They've actually found that they've been progressively seeing more problems with people of colour because they know what to look for. So I think probably don't spend, sorry, you've got a follow-up question, you probably don't spend as much time on white skin to assess it because, as I said, everything is based on white skin. So I feel like it'd be second nature, but lots of people have doubted themselves. And I've just today, actually, just before this webinar, I got the all go ahead with Radiography Journal for another paper, which is based on some around this. So finding out how confident therapeutic radiographers are in the UK at assessing, managing, and teaching skin reactions. And actually, within that, it shows a really big difference across the workforce. That I think it was around 72% of the people that responded, so about 406 people, were very confident at assessing or managing reactions, and then also teaching reactions on white skin, whereas only 42% of those people were confident with brown or black skin. So yeah, I would say it's taken I think you have to highlight it, I guess. That's what I'm trying to do. And then hopefully we can start to improve the equity from it. There's another question towards the end. Is Flamigel RT prescribed with a time limit? Can be used as required. So Flamigel RT is normally given, or when I've given it to patients, from day 0. So as soon as they've had their first radiotherapy treatment, you'd be applying it, and usually it can be up to 3 times a day. Obviously, they can decide when to do it. It can be put in the fridge. Lots of patients like to put it in the fridge, just to help with that cooling effect. And then as soon as the skin breaks down, if it does break down, they move on to the other products. I have known patients use it more than that, but it's preferable to try and use it just a small amount as you need to for applying it in that area. I don't think there's any more Q&As, but if you have any other questions, this was one thing that is often kind of asked me, is what are the challenges you face from this for the past couple of years, and just something to get across that it has been at the beginning mainly me, and then more people have been more interested in getting involved and trying to tackle this in their own areas. The RCR consent forms, they took a while, but eventually we got through, and then finding other kind of people or societies like the Irish Cancer Society, Society of Radiographers obviously, and things like that, and moving on from that element to try and keep pushing through the barriers and challenges. I think we're already starting to see some benefits. So I've used this story before, so I'm sorry if you've heard it, if you watched me speak before, but there were some midwives in Australia who've heard me speak through the podcast about skincare, and talking about the differences in skin tones. Then because of that, they've also started to look at their newborn babies, the tools that they use to assess their skin, and they've found that actually for babies of colour or brown or black skin, they've also always been looking for redness for changes, and now because of that one little kind of speech or podcast or whatever, that's caused quite a lot of nice change, positive change to help with equity. So yeah, hopefully, as I said in the talk, if you look at your kind of work areas, and it could just be as basic as looking at the consent forms or your protocols and see what it says, and then yeah, hopefully that can help power through with that. I think there's another question. Just going to try and find it. Elena says, very nice presentation, thank you. Are there multiple causes for these colour changes after radiotherapy? You mentioned melanin production, but also inflammation plays a role. There probably could be. I think the most basic answer to that is the response to the amount of melanin that's produced will be dependent on how much radiation is going in. So for someone who has head and neck treatment, for example, they might have up to 6 weeks or more of treatment. So we are giving them a lot of higher dose. It's more of a sensitive area. Their nutrition, hydration, etc. can become affected. So it means their wound healing or their cells don't heal as quickly enough. So I think apart from just the inflammation, I suppose it's all the other elements where the inflammation won't go down as quick because they're not eating well, they're not drinking, they're not looking after the area, that sort of thing. I think on a cellular level, I've tried to keep it basic as possible, talking about the melanin production. There is some anecdotal evidence, but it's not really been looked at in randomized control trials or anything with substantial evidence that some people with pigmented skin have a much delayed response to radiotherapy. So where in radiotherapy, we often tell patients their skin reaction or side effects may peak 10 to 14 days post-treatment. They haven't seen that, and it might actually be that it's even further, so maybe 4 weeks post-treatment or longer, and it's something that we haven't normally come across. A lot of these patients, that evidence has come from the new fast-forward fractionation. So for breast cancer, where it's gone from 15 fractions, so without a boost, obviously, down to 5 fractions. So slightly higher dose per day, obviously less dose overall. So I suppose there's quite a few different processes, if you want, at play. I think the inflammation side is interesting because if people aren't using a basic moisturizer, or obviously like Flamigel RT or things like that, then the skin isn't necessarily always hydrated, and that protection barrier can be slightly damaged a bit more. So I think that's one thing, is talking about the Society of Radiographers leaflet and information. I think it's quite important to get that baseline, tell your patients almost to prehab or prehabilitate their skin with a basic moisturizer or something until they start treatment, and then religiously try and get them to use that cream or ointment or whatever you're giving them in your department for them, and then post-treatment as well, they should continue. And got a couple more questions. So can you talk more about how the skin tool is used? So as I said, there's three main tools that I'm aware of. So RTOG, I'm trying to remember all the acronym full names, Radiation Therapy Oncology Group, CTCAE, which is common terminology criteria for adverse events. They're the two most commonly used. And again, that paper I talked about, which has just been accepted today, which is exciting. In the UK, 46% use the RTOG, the RTOG one. So both of those tools, you would look at someone's skin depending on if it's 0, which means no change. I think 1 is erythema. So, I mean, defining erythema as well is a whole other talk in itself. It could be, and how it looks on the surface is also quite difficult. And then number 2 onwards is when you might start to see dry or moist desquamation. So really, it's the clinician or the healthcare professional who's doing it to assess that person's skin. There is a patient-led version of CTCAE, which is used in clinical trials, called Pro CTCAE, but it isn't the most easy to use for patients, and it's quite vague. So that's really how you would use it. So, for example, if I saw a patient using either of those tools, and like the breast patient I showed with black skin, that's obviously, you can see it's a lot darker than the surrounding. There is a bit of skin breakdown. It might be that I would look at the central portion of the chest, and then as one part, and in my notes say central portion of breast is RTOG1. So that just says erythema on that one, or CTCA is also bright erythema, I think it says. And then for the inframammary fold where the skin had broken down, it was moist desquamation, I could say it's RTOG2A or 2B. I think it's 2B is for moist desquamation, sorry. And then CTCA is number 3. So it's quite varied between them. My argument with them is that you miss a lot of in between. So jumping straight from no reaction to erythema, which is hard to define, and then suddenly to some form of desquamation is difficult. So yeah, one of these things, the other tool, sorry, is what I'm trying to say is RISR. I can't remember the full term for it, sorry, but if you Google it, you should be able to find it from Australia and New Zealand. So that was designed, again, in the 1990s, and it is a validated tool, but it just says erythema or look for redness. So similar thing, you would ask the patient to fill out their version maybe at home on the way into the appointment, and it would be, how's your skin feeling? Is it warm? Things like that. So some of those elements are also in there. And then so me as a clinician seeing the patient, I would take those notes, assess the skin, and then put it into the hospital system. So that's how it would be. One thing from this just to add is that for the past sort of year and a bit, I've been working on trying to look at designing a new tool as part of working in co-design with people of colour, so especially brown and black patients, things like that, to look at the differences, look at the terminology that's appropriate, but also for different communities. I haven't really touched on language or how things are used in different kind of cultures across the world. But for example, in Punjabi, the language in India, one of the ones I've grown up speaking, there isn't really a word for nipple. So for describing someone's chest area. So there's things like that in different languages where it kind of adds another layer to this, saying that firstly, we're not giving them the right information on how their skin could look, but also the areas that we're asking them to look for is quite different. So in some areas, some cultures won't even say breast, they might just say chest. So again, trying to direct them. So yeah, that's why I'm trying to look at a different tool to help and find a way to do it better for people, I guess. I think there's another question that's come in. Does the amount of emollient matter in moisturizers recommended for patients? So I've had a question like this before, and it's quite difficult to know the percentage. So lots of manufacturers of creams, they might not necessarily put the fully accurate number in to begin with. Secondly, there isn't enough evidence to say a percentage-wise what should be too high or too low. It's more just the ingredient list, so like lauryl sulfates, things like that, metals that are in some old moisturizers or in like deodorants that we should be avoiding. So I think the amount probably doesn't matter as much, but if it's got paraffin, there's a lot of paraffin in it, we have to be careful about the amount there is. Without getting into too much specifics, that's probably what I would suggest. I think in the Society of Radiographers,
the full guidance that came out, so the full paper, not the leaflets, in 2020, I think that gives a lot of the evidence behind which aspects of a cream are good or aren't good. And I think there is something specific around emollients as well there, because I know some countries do it slightly different. And the reason I say that is I've been lucky enough to be part of the ESTRO, what does that stand for? European Society of Radiotherapy and Oncology. Their Europe-wide skin guidance, which I think we're hoping to submit for a final review in the next month or so, and hopefully talk about it at ESTRO in Glasgow in May. So actually, that element is also being looked at, I guess, that there is differences in what places across Europe and actually some places in the world recommend to emollients, or what ingredients are good or bad.